Hello everyone, welcome to today's live broadcast, Parathyroid Functional States, How to Define and How to Assess. I am Brenda Kelly Kim of LabRoots, and I'll be your moderator for today's event. Today's webcast is presented by labroots.com, the leading social media site for science professionals, and sponsored by DiaSorin. DiaSorin is an Italian multinational group and a global leader in the market for in vitro diagnostics. For over 40 years, the group has been developing, producing, and commercializing diagnostic tests for a wide range of clinical areas. DiaSorin tests are designed for hospital and private testing laboratories in the markets of immunodiagnostics and molecular diagnostics. Before we start, there are a few instructions. We want to hear from you during this interactive broadcast, so please ask questions or leave us a comment. Answers are always welcome too. You can do this by hitting the green Q&A button at the lower left of the presentation window and typing in your comments and questions. We'll try to get to as many of your questions as we can today. Want a better look? You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you can't hear or see this presentation properly, please let us know by clicking on the support button or use the Q&A button lower left to let us know. We'll try to make sure we resolve any issues. Now let's get right to today's presenter. We are proud to welcome Dr. Sudhaker Rao. Dr. Rao is the section head, Bone and Mineral Metabolism, and Director of Bone and Mineral Research Laboratory, Henry Ford Hospital in Detroit, Michigan, a position he has held continuously since 1995. It is the best bone histomorphometry lab in the state and one of the best in the country. Under his direction, the lab has been conducting both basic and clinical research and published extensively on the pathogenesis of bone fragility, age-related bone loss, mechanism of atypical fractures, and the role of vitamin D in parathyroid adenoma size and disease expression, and on parathyroid tumorigenesis. Dr. Rao has more than 100 peer-reviewed papers, 100 symposium proceedings, abstracts, and letters to the editor, and 10 book chapters. He is a founding member of the Indian Society of Bone and Mineral Research, which he helped launch in 1997. Dr. Rao has received a number of awards, including the Willard O. Thompson Traveling Scholar Award from the American College of Physicians in 1986, and the Frame Award from the American Society for Bone and Mineral Research in 1999. He is a fellow of the American College of Physicians and the American Association of Clinical Endocrinologists. I'll now turn it over to Dr. Rao for his presentation.
Good afternoon and good morning for some of you who may not be in the same time zone. My name is Dr. Sudhaker Rao. I am the head of the Bone and Mineral Division here and section head of Bone and Mineral Metabolism. Today I'll be presenting on parathyroid functional states, how to define and how to assess. These are my financial disclosures. I have a grant support from NIH. I am on the Speakers Bureau of the Lilly Company. I have a financial relationship to DiaSorin. I serve on an advisory board for the DiaSorin, receiving an honorarium from DiaSorin to provide this presentation. I will not discuss off-label or investigational use in this presentation. The objectives are threefold. First, to discuss the physiologic and measurement considerations, role of PTH in normal human physiology, measuring and interpreting serum PTH levels. The second part I'll present on assessing the altered parathyroid function, be it genetic, sporadic, acquired, or indeterminate or unknown, in which PTH assays become very important in deciding which type of parathyroid dysfunction the clinician is dealing with. And finally, if time permits, I'll present some clinical examples to highlight the above 4 different categories. I will not be discussing managing strategies since there are clinicians and non-clinicians, and I'll entertain questions at the end. The role of parathyroid hormone in normal human physiology is well known. Just to review briefly, parathyroid is a small gland located right behind the thyroid gland. It secretes parathyroid hormone and has a PTH receptor, and it works on 3 important organs: the bone, the kidney, and the intestine. In the kidney, it increases the renal tubular absorption of phosphate, and on the bone, it increases the bone resorption, and in the intestine, it increases the calcium absorption. And because of this tight regulation, serum calcium actually is maintained within a very narrow range. Although within an individual, it is much narrower than the normal reference range that is normally given. For example, within an individual, the calcium ranges only by about 0.5 milligram, whereas between individuals, it can range up to 2 milligrams. The next slide illustrates that the narrow range under which it functions. For example, most individuals will be in this small area, so the serum calcium varies very little in the normal physiology. As the serum calcium falls, the PTH rises. As the serum calcium rises, the PTH falls. And this narrow range is maintained constantly with the interaction of calcitonin, parathyroid hormone, and 1,25-dihydroxyvitamin D. The next slide shows the well-known actions of parathyroid hormone. The most important one, or the oldest one that we know, is increasing renal tubular phosphate excretion by inhibiting tubular reabsorption of phosphate. It increases renal tubular reabsorption of calcium, therefore the serum calcium is high in most individuals. At the same time, the urine calcium is relatively low. It increases the bone resorption by activating the osteoclast action and number, but also increases the osteoblast number and its lifespan. It increases the intestinal calcium absorption. These are the key elements in maintaining the calcium homeostasis. Although the well-established and most studied organs are kidney and bone and indirectly intestinal tract, there is some evidence to suggest that parathyroid hormone has actions on the vascular smooth muscle, hypertension, cardiac myocyte, brain, in terms of the psychic overtones. Whether it is related to the high calcium or the high PTH is still being debated. PTH measurements has a long history and evolution. The earliest measurement was mainly measuring the phosphaturic actions, commonly known as tubular reabsorption of phosphate, or TMP-GFR. The next generation of parathyroid hormone function study was mainly based on the nephrogenous cyclic AMP. Like any other polypeptide hormones, this will increase the cyclic AMP. And finally, in the late 60s and early 70s, we got into the C-terminal assays, primarily using the chicken or guinea pig for developing the antibodies. Unfortunately, C-terminal assays were not as discriminatory as the current assays. It was later replaced by the mid-molecule RIAs, and I'll show you the figure what they differ in terms of the epitopes. Then the most recent one are the intact parathyroid hormone assays. They went through 3 generations, so first generation, second generation, now the third generation. PTH is a straight peptide, 1 to 84 molecule. The initial carboxy terminal assays were mainly focused on this region of the molecule, and those are called the C-terminal assays. In the next generation, we had the mid-molecules, mainly looking at the mid-molecule of the PTH. And finally, the intact hormones used both the amino terminal, C-terminal as a capture antibodies, so that they were having a good antibody detection of the intact molecule. On little corner here, you will see that the 1 to 84 compounds in the third generation have a 92% probability of detecting the intact hormone, whereas carboxy terminal had only 78% of the probability of detecting the parathyroid hormone. So the newer assays are much better. I'll give you some examples of problems with the different assays currently. There's a recent assay that has been developed because of the different species of molecules that circulate. The most one that interferes with most of the commercially available intact assays is the 7 to 84 fragment, but the newer and most sensitive, what I call it probably is the high sensitive intact PTH assay that is developed by Diasorin has 0 reactivity to the 7 to 84 fragments, and probably this is will prove to be the best in the clinical practice. Interpretation of the PTH results depends on the role of vitamin D nutritional status, because PTH, 25-hydroxyvitamin D, have different relationship. Some have recommended that the vitamin D status be adjusted to the PTH reference range. However, many challenges exist to this approach. Very few, if any, PTH reference range are based on the prevailing vitamin D nutritional status, and 25-hydroxyvitamin D relationship is non-linear, as are many, perhaps almost all biologic relationships. Controversy about the optimal level of 25-hydroxyvitamin D, and then finally, how do we account for the calcium nutrition? Therefore, at the present time, the PTH assays reference range are based on the so-called healthy individuals without any reference to 25-hydroxyvitamin D. In the next few slides, I will illustrate the relationship between PTH assay and 25-hydroxyvitamin D. One of the oldest one comes from Dr. Gloth, where he looked at the 25-hydroxyvitamin D on the x-axis and PTH on the y-axis, showing that it is a curvilinear relationship. Around 25 to 30 nanograms, the PTH starts to rise, but it's not a linear relationship. As you can see, there are many with very high PTH levels. There are also many with the low PTH levels, even though vitamin D is present. The next slide shows a larger group of people, again looking at the intact PTH and 25-hydroxyvitamin D, again showing that around 30 nanograms per ml, PTH starts to plateau. And this was in early 2000, published from a data available from a clinical trial. On the other hand, with collaboration with the Diasorin and LabCorp, we analyzed close to 300,000 samples looking at the PTH 25-hydroxyvitamin D relationship. I know it's a crowded slide. What it shows is that at the age level, for any given age, patients with higher age have a higher PTH compared to the lower age group, and the number of people with higher PTH at the older age group is much higher than the lower age group. So it turns out that the PTH assay depends on the 25-hydroxyvitamin D level and also on the age level. I also looked at, although I have not published it, I thought I'll share this one, looked at the 7 different PTH assays in terms of their ability to detect. And it turns out the ROC analysis suggests that all 7 performed reasonably well with a ROC value of 0.8 to 0.92. Although we need more specificity without losing the sensitivity, so the more sensitive intact assays will be helpful for the clinicians in making diagnosis. We recently looked at cross-reactivity and problems in collections. In 2 assays, when we looked at the serum, there was a bias of 25 picograms. When we looked at the plasma versus serum, there was a bias of 12 picograms. When we looked at 2 different assays, serum, there was an 8 picograms. So the more sensitive the assay, the less bias will be. But usually in multi-replicate of the same sample, we get about 1.4 picogram ml, but between individuals, it's quite wide. Now I'll turn to the altered parathyroid functional status. In the ideal situation, the parathyroid hormone assay must conform to the physiology. It must be able to separate from normal from pathologic states, must be undetectable in non-PTH mediated hypercalcemic states such as cancer, PTH-RP producing conditions, granulomatous diseases. It must be elevated in almost all patients with PTH mediated hypercalcemia and all types of PHPT, must be undetectable in hypoparathyroid states. However, this ideal PTH assay is yet to be invented, since many patients with hyperparathyroidism will either have an elevated PTH value or non-suppressed PTH value. Some interesting features about the parathyroid gland: it is the smallest of all endocrine glands. It's only in milligram size, but a mere 2-fold increase in its size causes significant clinical manifestations. The normal weight is about 40 to 60 milligrams. Most individuals have 4 glands, but can range from 1 to 12 glands in number, can migrate along the midline down to the pubic ranges. Abnormal glands could be adenomas, hyperplasias, or carcinomas. 85% are single adenomas, 5% are double adenomas, 10% are hyperplastic, less than 1 are cancer. Weight varies from 100 milligrams in an adenoma to almost 45 grams, which is probably the world record so far as I know. Primary hyperparathyroidism is the most common cause of hypocalcemia. As I mentioned earlier, it has either clearly elevated PTH levels or non-suppressed PTH. So inappropriately normal value, a better way of expressing will be non-suppressed PTH, is pathognomonic of parathyroid hormone level. And in many patients, the PTH level usually above 20 picograms per ml. In cancer patients, it is suppressed, and in other granulomatous conditions, it may be suppressed in most of the time. It is the commonest cause of hypercalcemia in outpatients. It is the second most cause of all hypercalcemias. It is the third most common cause of endocrine disorder. Estimated incidence is 1 to 200, depending on which survey you use, and it can vary up to 1,000. Incidence rises with age. Usual age is 62 years. More common in women, 2 to 3:1 ratio. More common after menopause, perhaps related to the estrogen deficiency. There does not appear to be any specific racial predilection. Key features are that hypercalcemia is almost always elevated. That's how the clinicians detect the this condition. PTH is the normal or non-suppressed. 25-hydroxyvitamin D levels are variable. Alkaline phosphatase levels are also variable depending upon which part of the country or which part of the world the disease is diagnosed. Bone mineral density is frequently low. Clinical symptoms mostly asymptomatic but can be symptomatic. There are some genetic variants of the parathyroid disease. It is mostly sporadic. Very few are familial. There are multiple endocrine neoplasia types. And one condition called familial hypocalciuric hypercalcemia usually does not respond to parathyroid surgery, and the PTH assays are usually within the reference range. Occasionally they are elevated. Perhaps the newer assays will be better able to distinguish this condition from the usual sporadic parathyroid adenoma. Originally, there was a 10-fold rise in the parathyroid disease detection after Fuller-Albright suggested that calcium testing in all stone patients. There is a 4-fold rise after the biochemical data are introduced. Biochemical screening was introduced in the early 70s in this country. Although it has been stable from 80s to 90s, there is some suggestion that the incidence might be decreasing in the Mayo Clinic series. However, such decline in the incidence has not been found in the Henry Ford Hospital experience or in other centers. In an earlier era, the disease was euphemistically referred to as a disease of stones, moans, groans, and with psychic overtones. But over the past quarter century, it has changed from a disease with symptoms to a disease in search of symptoms. Therefore, the guidelines for asymptomatic hyperparathyroidism, how to manage them, who gets surgery, is developed. The traditional manifestations have been replaced by quality of life issues, BMD and fractures, some issues about the cardiovascular disease, diabetes and dyslipidemia, and the question of malignancy has been raised. So the traditional manifestations are still seen in parts of the world where vitamin D and calcium nutritional deficiencies are endemic. In addition to that, the growth of the parathyroid adenoma has also declined. For example, in 1940s, the average size of the gland was about 6.5 grams, whereas in the most recent series from the Henry Ford system is about 500 to 700 milligrams, which is much lower than it was. A precipitous drop in the adenoma size occurred in 1940s when the vitamin D was added to the milk. In contrast, even in the current situations, the disease presents much younger in the parts of the world where vitamin D deficiency and calcium deficiency is common, whereas it presents in the usual situation here with only 1.5 or 2 times elevation of the parathyroid hormone. In contrast, in other parts of the country, there is a 10 to 15-fold increase in the parathyroid hormone. We also looked at the 25-hydroxyvitamin D and the adenoma size, and we found that the lower the vitamin D level, the larger the gland size, the higher the PTH level, as one would expect. And similarly, we have looked at in the larger population of close to 1,000 patients, fully surgically verified. Again, the lower the vitamin D level, larger the gland size, depending upon size. And when we looked at the bigger glands versus smaller glands, the relationship continues to exist regardless of the gland size. It appears that the growth of the tumor is genetically determined, whereas the size of the tumor is determined by the vitamin D status. The newer, to summarize, primary hyperparathyroidism, the serum calcium is always abnormal. PTH level may or may not be elevated. In our series, it's about 2/3 will have non-suppressed PTH, about 1/3 will have increased PTH levels. Urine calcium is variable, alkaline phosphatase is variable, bone density is almost always low. Many patients are asymptomatic, and it is usually detected during routine biochemical screening. Primary hyperparathyroidism, both the type 1 disease as seen in the east of the world, and type 2 disease as seen in the west, are differentiated by the presence or absence of the bone disease. The new entity that has come up because of the frequent measurement of the PTH assay in osteoporosis management is so-called normocalcemic hyperparathyroidism. This clinical entity is somewhat undefined yet, but they almost always have normal serum calcium, but one must exclude all known causes of elevated PTH, such as low vitamin D level, low urine calcium, patients who have other drugs that are cause PTH elevation. So once excludes, then one is diagnosed with normocalcemic hyperparathyroidism, but it is unclear exactly what one should do with these patients. Now I'll switch to the secondary and tertiary hyperparathyroidism, where PTH assays have become even more important. The secondary hyperparathyroidism by definition has either normal or low serum calcium. It's almost always elevated PTH, frequently low 25-hydroxyvitamin D, and then all other features that I have listed on this slide. It's usually associated with the renal failure and or vitamin D depletion or both, but in the West it is mostly renal failure. Perhaps in the eastern part of the world, it's perhaps vitamin D deficiency. In this situation, there is a decrease in the 125-dihydroxyvitamin D, which is important for maintenance of serum calcium, and there is also retention of phosphate due to renal failure, both of which stimulate parathyroid hormone, causing continuous increase in the PTH secretion as the renal failure occurs. As shown in the early slides, as back as 1988, as the creatinine clearance declines, the production of 125 declines, and the rise in the PTH occurs. And it is due to the events. There's a disturbance in the blood-bone equilibrium, there's a decrease in the calcium absorption, and there's a set point abnormality in the parathyroid hormone secretion that leads to the development of parathyroid growth. In renal hyperparathyroidism compared to primary hyperparathyroidism, it could be a diffuse hyperplasia in the early stages, which can prolonged stimulation of parathyroid gland leads to the nodular hyperplasia, in which PTH levels are much higher, and then sometimes it can be associated with an adenoma within the hyperplastic gland. This is a slide of a study that we did a number of years ago in patients with renal osteodystrophy with skeletal disease present on the skeleton versus those who don't have the skeletal manifestations. The PTH levels are about twice as many in patients with bone disease compared to those who do not have the bone disease. I will switch to the next slide set, which is an important one. Give me 1 minute, please. We also looked at the relationship between the PTH levels and the bone disease in dialysis patient, and PTH here serves a useful clinical purpose for many clinicians. As long as the PTH level are below 500, bone disease is less common, whereas it's much more common above the 500 picograms per ml. In contrast to primary hyperparathyroidism, in patients with renal osteodystrophy, several species of the carboxy terminal or N-terminal truncated PTH molecules circulate. Therefore, interference with these molecules and separation of these molecules in the newer assays might be very useful. So the highly sensitive intact 1 to 84 assay that is developed by the DSORIN with very little or with no cross-reactivity 7 to 84 might be very useful in patients who are on dialysis. As a monitoring strategy, PTH measurements are required or recommended in patients with stage 3, 4, and 5 kidney disease. Depending upon the severity of the hyperparathyroidism, they are measured every 6 to 12 months or 3 to 6 months. Tertiary hyperparathyroidism, in my definition, and it is often misused, must have always hypercalcemia and usually preceded by long-term secondary hyperparathyroidism. PTH levels are almost always high, more than 1,000 picograms, and these patients almost always require surgical intervention. Let me switch into the hypoparathyroid states. There are several varieties of them. The key features are they are always hypocalcemic. They have either very low or very high PTH level, depending upon if they are due to deficiency of PTH hormone or due to the resistance of the PTH action on the target organs. Low or undetectable is idiopathic or post-surgical. High levels are seen in pseudo-hypoparathyroidism. Again, the PTH assays are very helpful in diagnosing patients with idiopathic hypoparathyroidism, particularly now that the PTH is available for treatment. A sensitive assay that is undetectable in such situations would be very helpful. Other corroborative laboratory data are listed on this slide, which are self-explanatory. The hypoparathyroid states is usually due to deficiency, either absolute or relative. The resistance is due to genetic or acquired. And there are few circumstances where there is ineffective hormone action due either to magnesium deficiency, chronic renal failure, or vitamin D deficiency. The symptoms are well known of the hypercalcemia, but I would like to concentrate on the complications, since many of these complications develop insidiously, and the first two complications on the right side are irreversible. Therefore, early recognition is important. Whether the newer PTH treatment for hypoparathyroidism will reduce the intracranial calcification is yet to be determined. One could use PTH assay to distinguish between PTH-related hypocalcemia or vitamin D-related hypocalcemia, depending upon whether they have associated symptoms. For example, cataract is more common in the PTH but not in vitamin D. Skin disease is more common in PTH-related hypocalcemia than in vitamin D-related. Soft tissue calcifications are more frequent in PTH-related than in vitamin D-related. One could also use the PTH as a characteristic feature. If it is low or high, it is due to the PTH related. If in vitamin D related, it's almost always high. And finally, normal levels of PTH are due to calcium sensing receptor mutations, magnesium deficiency, or ineffective, whereas it is always high in chronic renal failure, vitamin D depletion, or pseudo-hypoparathyroidism. PTH assays are also helpful in distinguishing clinicians whether it is due to hypoparathyroidism or due to hungry bone syndrome soon after surgery for a patient with primary hyperparathyroidism or for thyroid surgery. Traditionally, we depended on the phosphate levels, but with the newer assays and faster assay time, it is possible to determine whether the hypocalcemia is due to hypoparathyroidism, in which case it will be low or undetectable, or is it due to hungry bone syndrome, in which case it will be quite high. This is a case of pseudo-hypoparathyroidism, so showing the short stature and short metacarpals, a patient with the PTH resistance. This is a case of intracranial calcification in a patient with post-operative hypoparathyroidism, showing bilateral basal ganglion calcification and also cerebellar calcification, as you can see here, and patient can develop ataxia due to this. Unfortunately, the current PTH treatment available may not reverse this, but early treatment might prevent this. Until then, we will not know whether the PTH treatment will prevent intracranial calcification. In conclusion, I reviewed with you physiologic and measurement considerations. I discussed the PTH measurements and vitamin D effects on PTH measurements, discussed various types of PTH measurements and possibility of newly high sensitive 1 to 84 intact PTH assay might be very useful because of its low cross-reactivity to 7 to 84 molecules circulating. We discussed the phenotypes of altered parathyroid states such as primary, secondary, tertiary, normal calcemic, and various types of hypoparathyroidism. And I hope my presentation has been very helpful and informative. Since there is some time, I'll spend trying to give you some examples of cases. Here is a case of severe hyperparathyroidism. Hardly one can see the bone out figures before parathyroidectomy. And 6 months after parathyroidectomy, the bone is reconstituted, but the deformities remain permanent. Here's an example of osteitis fibrosa cystica or brown tumor. before a radiologic picture, and one can see that the calcium extruding from the knee here from that brown tumor. Another example of cortical thinning and with fractures and a regular jersey spine showing on the right side, and full of bone marrow fibrosis that occurs in primary hyperparathyroidism, somewhat similar to that occurs in renal failure. And this bone marrow fibrosis is an important determinant of the EPO resistance in dialysis patients. The more PTH, the more marrow fibrosis and more resistance to EPO. There is a visible parathyroid adenoma in a stunted lady from eastern part of the world. Sometimes you can get soft tissue calcifications that can be seen in patients with renal osteodystrophy, and X-rays will show full calcifications, and this may be due to excess parathyroid hormone, phosphate calcium product that is causing the deposition. Sometimes you can see a clubbing of the fingers due to subperiostral erosion and loss of the terminal digits, and one can hardly see the terminal digits in the X-ray of this particular patient that I showed you earlier. One can also see severe resorption of the symphysis pubis due to very high PTH levels, and that can progress, and sometimes they can develop protrusio acetabuli and deformities that cannot be reversed due to severe hyperparathyroidism. One can also see severe osteoitis fibrosis cystica in the symphysis pubis, in the greater trochanters here that can cause osteoitis brown tumors. This is an example of a regular jersey spine in a patient with renal osteodystrophy, and a close-up view of the subperiostral erosion on the radial aspect of the femur. Sometimes you can see it on the lateral end of the clavicle with resorption. Again, marrow fibrosis that I showed you earlier. I think I will stop here and I'll entertain the question. Over to you, Don.
Thank you, Dr. Rao, for bringing that information to us. Excellent presentation. Before we get started with our audience questions, I just want to remind attendees how they can submit questions to you today. Questions can be sent via the green Q&A button at the lower left of the presentation window. If you click on the green Q&A button, type in your question in the box that appears. We'll read it out to Dr. Rao and get his feedback for you. I just want to give our audience just a few minutes to find the button and ask any questions that they have, but that was certainly an informative presentation, Dr. Rao, and the illustrations of what can happen in this kind of disease process, I think, are especially valuable for our attendees today. So we'll keep an eye here on the Q&A and see if we have anything incoming for you. And that is the green Q&A button is at the lower left. If Dr. Rao, if there's any other slides or any other information that you have while we're waiting for questions, you're certainly welcome to do that. Okay, we do have a question in our queue coming up. And an attendee asks, since vitamin D is important in PTH function, how much direct sun is required on a daily basis to maintain adequate vitamin D levels in the body?
Okay. That's a very good question. In general, the simplest way is to take 1,000 to 2,000 units of vitamin D on a daily basis. In cases where the vitamin D level is very low, and there's urgency in replacing it, particularly if the PTH levels are elevated in concert with low 25-hydroxyvitamin D, then one could use pharmacologic doses like 50,000 units every week for 8 to 12 weeks. But in general principles, 1,000 per day, probably forever, should be helpful in most circumstances.
Great, thank you. We have another question coming in. Does the 784 fragment have any physiological activity?
That is actually an excellent question. although we do not know the full in human physiology, but 7 to 84 when injected into the rats can cause hypocalcemia. Some people believe that it may be an antagonistic action of the 1 to 84 and secreted directly from the parathyroid gland, but it's proof that it actually exists in that form from the parathyroid gland is not there. So at the present time, we do not know of its physiologic function, but it interferes with the assay, and there's some experimental evidence to suggest that it may be a hypocalcemic hormone secreted by PTH, but further repetitive tests by other investigators is needed. Hope that helps.
Great, thank you. We have another question. At what calcium level should one consider the involvement of PTH?
I assume they are asking about the hypercalcemia, but I'll answer in both ways. As long as the serum calcium is above the reference range, then the PTH measurement becomes imperative. Whether it is normal or elevated, then it is a diagnostic of hyperparathyroidism. In contrast, in the low calcium range, the PTH level becomes important. If it is very low or undetectable, it is consistent with hypopara. But if it is very high, then one genetic causes may be a possibility. But within the reference range, PTH becomes less important. In most osteoporosis screening programs, the PTH levels are within the reference range. I hope that answers the question.
Thank you. Okay, we do have another question from an attendee who asks, is there a single blood test to detect any abnormalities in parathyroid function?
Oh, that's an interesting question, but I'm not sure I understand the question. As long as the calcium is normal, there is no single blood test. So in the usual clinical practice, as long as the serum calcium is normal, there is no reason to measure the PTH, except in the circumstances where you need to measure the PTH, such as patients with osteoporosis, where you suspect calcium deficiency or vitamin D deficiency. I would say if one has to do a single test to determine the calcium and vitamin D balance, perhaps more and more I think about it, PTH probably is more pragmatic than any other single test. But I don't think we have a single test, unfortunately, like we have for thyroid function using TSH as a single test. But in the case of calcium metabolism, you must have calcium and PTH at the same time to be able to interpret. Over to you.
Okay, thank you. Our next question that we have, can calcium and vitamin D supplements raise the level of thyroid?
I'm not sure he meant to ask thyroid or parathyroid, but I'll answer both. The first part of his question, the way he addressed, calcium and vitamin D level supplements do not increase the thyroid hormone levels. However, taking calcium supplements with thyroid supplementation may impair their absorption and might alter the test, but does not directly alter the test. It might alter the test because calcium interferes with thyroxine absorption. On the other hand, if he's asking parathyroid, yes, calcium and vitamin D supplements do change the parathyroid hormone levels. The lower the vitamin D and calcium intake, the higher the PTH, and vice versa. So in otherwise healthy individual taking low calcium and low vitamin D, PTH assay becomes useful as a global test to assess calcium and vitamin D nutritional status. Over to you.
Thank you for that. As a following on from that question, do sometimes patients who take thyroid supplements, is it advised that they take a calcium supplement separate from that, or maybe don't take it with milk? Is there a problem with it directly interfering with thyroid medications?
Yes. In general, the answer is yes. They should take the thyroid medications away from the calcium. In addition, by the way, iron also interferes with the thyroid hormone absorption. So the thyroid pill must be taken at least an hour before they take calcium and iron supplements. The practical way would be to take their calcium and iron supplements with their meals like breakfast, lunch, or dinner, whereas thyroxine supplements should be taken first thing in the morning only with water away from food. Over to you.
Great. Okay, thank you. Thank you for that answer. I don't see any more questions in our Q&A queue. I just want to give our audience a couple of minutes if they want to enter any more questions for you. And I don't want to leave anybody behind. And okay. I don't see anything else coming in. Dr. Rao, since we do have one. Great, there we go. An attendee asks, what's the highest level of dosage for a thyroid supplement?
I'm not an expert in that area, but I can answer as an endocrinologist. It depends on the body size. The rough rule of thumb is 1.6 micrograms per kilogram body weight. So there's no high or low. It depends on individual patient, individual circumstances. For example, patients who had gastric bypass surgery may require more hormone than others. Hope that answers. Thanks. Over to you.
Okay, great. We've had a couple of audience members ask about this presentation. Just to let you know, presentation will be available for on-demand replay for about 6 months after today's live event. So that will be available for audience members who are asking about information from this presentation. And I don't see any other questions, but I did want to address that about a couple of people who had asked about information being available after today's live presentation. I want to put it back to Dr. Rao. Do you have any final comments or advice for our attendees on your topic today?
No, I don't have any comments other than I hope my presentation was very helpful. I want to thank the audience for taking the part away from their schedules to listen to me. And I hope they will find the webinar to be available in the next 6 months to be useful in their clinical practice. And I'm hoping that the newer PTH assay will be helpful for clinicians to make the diagnosis a little more securely than we had in the past. Over to you.
Thank you, Dr. Rao, for your time and spending your time with us today and bringing us this important information. I also want to thank our sponsor, DiaSorin, for making it possible to bring this presentation to you. As I said, today's webcast will be available for on-demand viewing through December of 2016. Any attendees today will be receiving an email from LabRoots alerting them when this webcast is available for replay, and we would invite you to forward that email to any of your colleagues who may have missed today's live webcast. If there was a question you didn't get to ask or that we didn't get to today, we will definitely follow up with you via email. Once again, I'd like to thank DiaSorin for providing this webcast and Dr. Rao for his time. That's all we have for today. We hope we see you again. Goodbye.